of Cape Town and Ghent University. Our professor, Dr. Peter de Kat and Dr. Rien van den Bossen are our guidance here in Belgium, but they couldn't be here today due to other obligations. So this research project is about exploring the integration of facility-based and community-based health teams in the Cape Town District Health Services, a realist perspective. The upcoming 30 to 40 minutes, we will be talking about our first of all, the background and our literature review. Afterwards, we will share our methods, our findings, and of course, our discussion and conclusion. And the last dia will show you our references we used. Afterwards, there will be some time to ask questions and interact and share your thoughts with us. And we are very much looking forward to that feedback. Yes. So where did our research question actually came from? As we see here, the community-oriented primary care system is very prominent in South Africa. It's very important. It combines the preventive, promotive, and curative care. It focuses on access to healthcare for those who do not come for the care, and they rely on CHWs. And research states that it could improve health status and save costs to work with CHWs. As we found in this research from Mash et al., they made up a guide to the implementation of COPC. And one of those 10 elements that they set up is the facility-based and community-based teamwork, which is for us, for our research project, very important. As you can see, it states that good teamwork needs to build a relationship and function as an integrated team. And this requires regular meetings to build this relationship, to coordinate activities, to plan training, discuss problems or challenges, and review the information of the health needs of the community. As we see that CHW is a very important bridge between the communities and the healthcare services, we also see that they face a lot of challenges, as in the next research from Murphy et al. They found challenges like that the CHWs not always feel respected, not always feel like integrated in the facility as such, that their job specifications oftentimes are misunderstood, and that there is confusion about their work roles, and that there are feelings of mistrust between the facility staff and the CHWs, which can undermine the cooperation between the two. In the same research, they found that a strong and supportive relationship with the facility management is reported as an indication to the success in CHWs, their work. So our research question came out of this research project that we want to explore where this comes from, and where in the regions that there are interventions to integrate the community-based services more in the facility-based services, and evaluate these interventions and find where this is already going well, and what is helping to tackle this mistrust, to tackle these feelings of not being respected, and what are still challenges in these interactions. So now Cédric will go on with the method that we used.
Yes, so hello everybody. For the study on the interaction between the facility and the community-based teams, we used a qualitative design, and it will be evaluated by a realist evaluation. A realist evaluation is a specific type of evaluation that focuses on the mechanisms and how they are leading to certain outcomes. We're mostly interested in why they lead to their outcomes rather than if these mechanisms lead to certain outcomes. For this why question, it's interesting to us to compare between different areas, and that's exactly what we did. This study is a collaboration between the University of Ghent in Belgium and the University of Cape Town. And during the months of April and May 2024, me and Lotte came to South Africa for our data collection in two areas. The first one being Atlantis, the area around Westville Hospital, and on the other hand, the Fishhook and Ocean View area around Falls Bay Hospital. Our study population is formed of all healthcare workers that are involved in this interaction facility and CBS. And our data source are in-depth interviews with our participants until data saturation was reached. For us, this was reached at about 17 interviews with a total of 21 participants. After this, we found as researchers that no additional data came up. All interviews were being auto-recorded and transcribed and afterwards anonymized. In the month of September, we organized a member checking. These were 3 Teams sessions where our participants could join, where we could present our findings and discuss and reflect with the participants to make sure we're not jumping to the wrong conclusions. Another data source are direct observations of these interactions, which we attended as well. To move on to our findings, this is an important slide to us because it's very illustrative for a realist evaluation. It shows the mechanisms in the middle leading to beneficial outcomes on the right, and the context factors on the left influencing this interaction, facility and CBS, to help us understand why the mechanisms in the middle lead to the outcomes on the right. In the middle, we see the mechanisms. We identified 4 big categories, which will be discussed further. The outcomes on the right, overall, there's beneficial outcomes for a better interaction on different levels. On patient level, including better patient care, on the level of healthcare workers working together, there's better teamwork, better communication, more respect, more trust. And in the broader picture, we also have positive outcomes on healthcare systems as a whole. For example, reduced hospital length of stay, public health issues, etc. I'll move in on the context factors as well on the left, which help us understand why certain interventions to help this interaction lead to better outcomes in one place, but don't necessarily do in the other. We have strict context factors where we have little to no influence on. For example, a smaller community. In a smaller community, it's easier to build personal connections and to have better outcomes. On the other hand, limited resources can be a big challenge for this interaction. On the other hand, we have factors that refer to the system that is in place. We see good referral pathways in both areas where we collected our data. We see everywhere that consistency and frequency of meetings is very important, as perceived by facility staff as well as the CBS. For example, frequency of MDT meetings, multidisciplinary ward rounds. We see that
Cédric, you're muted.
I suppose you can hear me again?
Yes, we can.
Was I muted for a long time?
We just had ward rounds and then you stopped.
Oh, yeah. All right. To move on, we see that with the communications meetings, if the CBS is part of it, it could be a very good context factor because it can help to identify glitches in the system and have that feedback. We see that we observed home visits by the registers in one area, not yet in the other, but we've heard that now it's already been introduced in that area as well. But it's interesting to see the differences in the 2 areas at that point. Also, the open door policy, meaning that CBS workers could just walk in to the hospital and interact with facility staff. This was very present in one area, but not in the other. Also, WhatsApp group as a medium for communication has been a recent development and came up also in both areas. I'll leave the word to Lotte.
Lotte, you're still muted.
Yes. Okay, so now we're going to discuss the 4 mechanisms that we found as very important to facilitate this interaction, or that can still be a challenge for this interaction, and to have these outcomes that Cédric discussed before. The first one is power dynamics. We see that power dynamics play an important role, and we also see that from out of the facility, they try to flatten out those power dynamics, tackle those power play, and try to invest in not making it that doctor-centric anymore, to make feel the community-based teams more part of the healthcare system. We see that it helps to invite the CBS team as part of the MDT meeting, but also as part of the ward rounds, for example, and that makes them feel more acknowledged. It puts them in a positive position for building up the relationship and becoming partners. And feel more as part of the healthcare system. On the other hand, we still see that acknowledging CBS can be a challenge, and regarding CBS as part of the healthcare system can also be a challenge. For example, if you look at the CBS workers coming into the facility in their uniforms, and they feel that they are not seen as colleagues and have to wait in line with the patient, and where the patients are waiting, so that they don't get seen as colleagues, and that's kind of frustrating for them because they want to help and they want to be part of that system, and we see that it's sometimes still a challenge. We also see that there is for certain regions, there's still a threshold for communication because they fear to disturb the doctors. They are very aware of the workload, the burden of patients that needs to be seen in the hospital. So they don't always feel like they can instantly contact them via WhatsApp or via, for example, that open door policy. That's in one region very okay. In the other region, there is no system to have that quick response. And that's a lack, that there is also a lack of that quick response. And they experience mostly that high threshold for communication. Which is a challenge for tackling that power play, of course. What can be helpful is be open-minded, be humble, and try to learn from each other, willing to learn from each other. We see that the CBS team is the expert of their community. So as a facility staff, you can learn from the CBS team. And of course, the other way around, the community-based team is also very willing to learn from the facility staff. So that works in both ways, but that is, if you do that in a humble way, can tackle the power play between the two and is very helpful in the interaction. The next one is the respectful communication. If you want something done, ask nicely. Don't command, don't obey things, but just ask nicely. Treat people how you want to be treated. It's something that tackles power play, and have open communication. If something went wrong, if there is a problem with a patient, just ask and communicate openly about the problems that you faced, and ask if there is anything you can do to support. So that respectful and open communication between the two teams is really important. Having this give and take relationship is something that is beneficial. So knowing that you help each other. So if I do that, I know that I will also get something back. It goes in both ways. And having a connecting person in a facility, like a family physician or a social worker, that sees the value of having the CBS team to have this holistic approach of taking care of patients, can be beneficial in tackling power play and in helping to integrate this community-based team in the facility. Yes. The second mechanism is a broad theme about strengths or strengtheners of the CBS team. It helps, it's beneficial to have a CBS team that is a long-standing member of the community. They are respected, they know the community, they are the eyes and ears on the ground. It's very helpful. It facilitates the interaction. If you have a CBS team that's very motivated, that has a positive attitude, that goes over and beyond, and we got that from a lot of interviews, that the CBS teams we observed have a very positive attitude and really went beyond what they had to do. And the fact that they are willing to work cohesively, that they don't have their own agenda but are just there to help, is also beneficial for having a good interaction. That willing to work together with each other, not taking each other's jobs over, understanding what each other's roles are, makes it easier to work together. Challenges for the CBS team we see is their level of training. We see that, for example, in mental health, they told us that it's difficult for referring for mental health because there was not a lot of training in the mental health field. It's difficult for mental health patients, and that they lack training in that part. But also in other topics, it might be beneficial to have more moments of training and more refresh moments, as we got from feedback in the member checking, that the CBS team is really willing to have those refresh moments and training moments to get better or improve their medical knowledge. Another challenge is the fact that CBS is quite nurse-driven, but they also face a lot of social challenges. So they have the lack of having that social worker is something that came up oftentimes. And we also see here in the last quote that it's been brought up multiple times that they do need some extra social work support. They can find it in the facility, but it might also be a solution to have a social worker in the community-based team. And the last one is the fact that CBS team sometimes feels overwhelmed by their growing responsibilities. They told us they have their wellness hubs coming up, they have their household assessments, and on all the referrals that they need to do, that it sometimes gets overwhelming. And in that way, it helps them to have that facility staff support in that growing responsibilities to maybe get a better overview of all those things. Then we have two smaller mechanisms and themes we want to discuss with you. The first is understanding each other's roles. This is pretty obvious, but it was sometimes an issue to know what are the indications to refer to the CBS team. So having insight in what can CBS do in the community, what are they capable of, what are the possibilities, because they do also face the limited resources in the community, of course. So having those insights in what are CBS indications is really important. And by having that interaction, you can get to know that. Understanding the circumstances that CBS works in, this is about safety, but also about those social challenges that they face. For example, when they cannot find a patient that is referred for follow-up because of the addresses were not properly on the referral forms, or it was the wrong address or the wrong contact information, they cannot find that patient, and then they have a failed follow-up, and that goes back to the community, and then that goes back to the facility, and then they don't understand what went wrong, but that's just because they don't have the right address and they looked for the patient everywhere. So understanding those circumstances for the facility that CBS has to face is really important to make sure that the referrals are proper, have proper information, have proper contact information, so that it makes the work of the CBS a little bit easier. We also see that there was a challenge of not knowing the level of training. So we discussed that the level of training is a challenge for CBS, but there's also the fact that the facility staff is sometimes not aware of what training that the CHWs get and what are the capabilities. So especially when the registers were doing home visits, they told us that they had to find it out while having that one-on-one contact while doing the home visits. When, okay, so this is what you know about this topic and this is what you know about this topic. So that is still a challenge to make clear about each other's roles and knowledge. And we also see the expectation mismatch of the home visits as a challenge. What can the registers do when they are on home visits? They don't prescribe medication, but there was an expectation, and those things, they'll be clear about what is what can be done on home visits, and that something needs to be stated upfront. I think this is a really nice quote of one of the CBS nurses. As long as each understands, this is what I bring to the table, this is what you bring to the table, how can we, whatever that is, make it work, because it's a make work situation. I think that's a nice summarization of this mechanism. Then the last one is the personal connections. Having that human connection with each other, that interpersonal relationship, and knowing each other makes it easier to interact and facilitates the interaction between the two teams, which is quite obvious, but something that was really important, because if you don't know each other, it's harder to ask and go in the hospital, ask questions, or take your phone and have that instant communication via WhatsApp if you don't know each other. So it's an important facilitator, but quite obvious. But you do need to invest and have that regular interactions, so you can get to know each other, introduce each other to one another, and this will definitely strengthen over time. That's just how relationships work. Have that open curiosity, the same with willing to learn from each other, be humble. I think that's also very important, and be open to get to know each other. Having that personal interaction makes it easier to make things happen on the ground. Okay, so in conclusion for our discussion, those were our 4 mechanisms. In a setup system within a specific context, we find that the integration of community-based health teams and the facility-based health teams gives potentially multiple positive outcomes when there is effort from both sides to invest in the consistency, in the frequent interactions, in flattening out those power dynamics, in strengthening the CBS team, understanding each other's roles, and having and investing in those personal connections. If we see that there is effort to bring the community-based teams regularly in the facility, and there is the effort to bring more facility staff into the community, we see that this last thing is really something that can be was received very positive. Having registers every one time in the 2 weeks doing home visits brought so many benefits for the CBS team. They felt more supported. There was from the facility staff more insight in the CBS indications and in the circumstances, so they understood everything more properly, what was happening on the ground. They understand more the level of training, the people they work with, the medical knowledge on the field, so they can make proper referrals. And of course, having that one-on-one connection in doing that home visits together with the CHWs and the CBS nurses makes a better interpersonal relationship. And that one lowers the threshold for communication and makes it easier to get in touch when there are quick questions or when there are problems on the ground. Of course, we want to mark that it's not that easy to send out that staff. So I think it's very useful to have the registers doing home visits, but there's asking questions to also send family physicians and medical officers to the community to do the home visits. But of course, yeah, we are limited due to the resources and of course the workload. I think the burden in the hospital is already quite high of patients. So doing home visits on a regular basis, we understand that it's not that easy to implement, but we do see that it brings a lot of benefits.
Another topic that we wanted to highlight in this discussion is the use of alternative communication lines in the interaction between facility and community-based teams. The first one being the WhatsApp group, which came up a lot in the interviews, and in general, it was perceived as a very good thing. It's quite a recent development, especially during COVID. The use of a WhatsApp group grew exponentially. In general, we do think it's and it came up quite a lot that there's quite some benefits, including a quick response system. In a WhatsApp group, it's very easy to ask a question from facility back to CBS or vice versa. It also lowers the threshold for communication. CBS workers mentioned in the interviews a lot that sometimes they experience quite a big threshold to ask questions to facility staff. and the WhatsApp group can help to lower this threshold. Also, everybody is included. Everybody is in the WhatsApp group, both teams, which helps the feeling of working at the same project as being part of the same healthcare team, and to regard the CBS as part of that as well. We do have some critical remarks about this as well. Because a WhatsApp group, we have questions about patient privacy. Is it always the ideal medium to discuss this, especially in these GDPR regulation times, etc. And workload-wise, it is easy to just ask questions and it lowers the threshold for communication. But on the other hand, a WhatsApp group is a 24/7 kind of thing. Everybody can ask questions at all times. Many people use WhatsApp, the WhatsApp platform, for private and professional measures. So there could be a fine line between work and private life. So this could help. This could lead to an increased workload potentially and feelings of being overwhelmed. We do think that it could be a very interesting research topic for the future to investigate the pros and cons of WhatsApp in healthcare, and especially when talking about communication between different healthcare workers. A second alternative communication line is the open door policy, which we've observed in one place, but not in the other. We see in one place that the NGO of the CBS was located geographically right next to the hospital, which makes it obviously much easier for CBS workers to just walk inside the hospital and interact with facility staff. We see this can be very beneficial to serve as a quick response system, just like the WhatsApp group. And as we've discussed earlier, it's the importance of personal connections, to be physically around each other. It can help to improve these connections in real life as well. As with the WhatsApp group, we do have some critical remarks about concerning workload, because of course there is already a big workload on both sides. And if we see that CBS workers could just walk inside the hospital and interact with facility staff, this could be an additional workload potentially and be overwhelming. Okay, to move on to the conclusion, we've seen that the integration of facility-based and community-based teams, it requires an effort from both parties and on several aspects, as we've discussed in the findings, including frequent interactions and being consistent with it, tackling the power dynamics, strengthening the CBS in itself, and understanding each other's roles. Also improving these personal connections, as we've discussed. We have, as researchers, observed a great willingness to work on this interaction from both teams and the sustainability of these engagements. Probably because both teams really experience the benefits and see the positive outcomes. We see that a good working interaction leads to beneficial outcomes on several levels for patients, for healthcare workers, and in the bigger picture for healthcare systems as a whole. At this point of our research, keep in mind we haven't concluded all data analysis yet, but as we've discussed in a discussion, we've identified some suggestions for future research. For example, the efficacy of WhatsApp, of a WhatsApp group as a communication system in healthcare interventions, with some critical remarks involving patient privacy and workloads and setting boundaries. So we think this could be a very interesting topic to further examine. And the second one being the evaluation of the home visits. We've seen that the registrars go on home visits and it leads to beneficial outcomes. So we're very curious if this could be integrated as a standard practice of care in healthcare settings. So to conclude, we still have a slide with our references mentioned. Here we will conclude this presentation. Thank you all for being here, and I will give the word back to Professor Taslim Ras. Thank you.
Thank you, Cédric. Thank you, Lotte. And the one downside of the team's presentation is that you don't hear the applause like if you were in the same room. So I'm gonna applaud you on behalf of the entire group. Thank you very much. I think that was a very good overview of the project that we ran, and you presented the findings in a clear, concise way, always appreciated. And you've left sufficient time for decent discussion and questions. So before I open up to questions and discussion, I want to just say whoever needs any type of CPD points, please your name and your registration number in the chat. And then we'll submit. The session is being recorded, so we'll get that off the minutes and then we'll submit that to the relevant organization. Thanks. Any questions, colleagues? Can we stop sharing and then we can have a bigger screen and see whose hands are up and whose hands are not up? While we're waiting for people to come up with questions, I really like the quote that you highlighted. And the one line I really liked, which maybe speaks to almost the entire ethos of the study, is it's a make-work situation. Yeah, it's being able to make something happen out of, very little without any extra resources. They were able, I mean, both sides were able to build, it's this thing about when two entities come together, there's a third type of energy that gets generated, which is what I think you guys described. Hannah?
Hi, everyone. Thanks, Taslim. Let me just put on my camera quickly. Thank you very much for the presentation. It was a really clear overview of all the issues that happen on the ground. I was just curious, and apologies, I might have missed it because I joined 5 minutes late. You're coming in from the University of Ghent, and I was just curious that obviously in South Africa we're very obsessed with COPC. What is the sort of global appreciation or lack of appreciation or the direction that it's going in? I have seen some literature from American sites, but nothing from European centers. So I was just curious what the European perspective on COPC was. Thanks.
Yes, thank you for your question. For us, it's actually some piloting project that's going on in Belgium at this moment. There is still limited research about that, but for example, Dr. Doreen van den Bossen, or postgraduate that is or doctorate that is guiding us. She's doing those projects in Belgium and Ghent and in Antwerp. They are going on. And we've seen a study in COVID that showed building trust between patients and community health workers is helping also the family physicians. And that's a research project that we've read and is conducted in Belgium. But the other things is just evaluations of the piloting project that are going on. So we are still very curious about what is coming out of there. So we're also still curious to learn from other countries where the system is a long-standing part of the healthcare system.
Yeah, so like, for example, with the integration of CHWs, this has only been the case since 2020 that they have been introduced in the healthcare system, and the pilot projects are still running. So it's a very recent thing for us to work with community health workers, whereas there's a long tradition in South Africa. So it's very interesting to us.
Thanks, guys. Steve?
Hey, Hey, Cédric, well done. It's a really fantastic presentation, and you did real justice to the question, which is a key one in community-oriented primary care, how the two teams interact or don't interact. So some of the issues, and I'm interested, my question is, to what extent did the data reflect this? Some of the issues are at managerial level, because the community health workers report through the NPO managers, and the facility-based staff report through the provincial health services. So there are two parallel systems reporting to different managers, and that at a higher level, that is negotiated through a contract, which is a one-way contract. It's a contract from the province to the NPO, and the NPO depends on it for their income. So it's an unequal relationship at that level. What I hear on the ground is, no, the managers just, they're in their own world, and we must just make it work on the ground in the best circumstances. But where it doesn't work is where the people on the ground have not got together, and the managers are not helping either. So I'm just wondering if that came up. It's a kind of structural framing of this relationship that I didn't hear you talk about in your data.
That's a really good question. We mostly focused, actually, like you said, a ground-up approach from the workers in the field, and our participants were mostly CHW, CVS workers, family physicians, and social worker, physiotherapists, so everyone on the ground. And we only interviewed one facility manager and one CBS coordinator. And we did receive feedback about some political factors that can be of influence but cannot be changed from the CBS coordinator. But we did not go into deep into that subject because we were focusing in our research about that personal interactions more than higher up.
Yeah. So that is my impression, is that people just get on with the job at a operational level. But there is this disjuncture at a higher level, and I'm interested to know to what extent it perpetuates this dual system in a way. In the worst scenario, in the best scenario, people work together despite the those issues. Yeah,
it is a very interesting question indeed. Also, in our realist evaluation, we've identified these now as context factors. Because with starting from the realist evaluation, we make a CMO hypothesis, starting from the mechanisms that lead to the outcomes. And so we've mostly focused on these mechanisms to explain from the idea of the realist evaluation why these mechanisms lead to these outcomes in different areas. And thus we've identified the bigger contexts, political, systemic factors more as context.
More generally, yeah, I get it.
But it is a very interesting topic as well.
So Steve, we had tried to recruit some managers to be interviewed because the intention was to get some type of idea of whether there's an existent policy which speaks to integration. Because if there is a policy, the managers would be looking to enforce that policy. Unfortunately, just in terms of the timelines, we weren't able to include them. So it's certainly an area to look at from a policy perspective.
There's the COPC position paper, and the framework that we published, but there is a provincial position paper now, which talks about this thing.
So very much is this is almost like what Bernard Gader speaks about, the street level bureaucracy.
Yeah, exactly.
You know, the people doing things on the ground in a way in which it makes sense to them.
Yeah. But equally, if they don't want to do it, nobody's going to, check up and there's no consequence of.
Any other comments or questions, colleagues? Yes, Ruth.
Thanks, Taslim. Hi there. Ruth Corney from the Knowledge Translation Unit. I might need to rely on my colleague Kosi, who's in the meeting as well, too. I see you've put your hand up, Kosi. Excellent. Maybe you should ask your question first. My particular point around this was to respond to what you're talking about there, was that community health workers as employed by the MPOs have not been permitted recently to work within the facilities. And I wondered whether you came across that in your 2 sites. Because they're not employed by the province, and how that's compromised the interaction between the facility staff and the community health staff. But I'd like Kosi to add to this because you've been working more directly with this than me, Kosi.
Kosi, go for it.
Hi everyone, I had a completely different question, but maybe you can answer Ruth's question first and then I'll add on. If that's okay. Thank you.
Cédric, Lotte, I mean, so Ruth asked an important question. You alluded to something in your presentation around the CHWs having to stand in queues when they went to the hospital in terms of integrate. What was your sense in terms of them being allowed to come and work in the hospital? Was there any mention made about that within the facilities?
I think for now, what we observed is that when they bring patients to the hospital or they get in contact to refer patients to the hospital, they're not really seen as part of as colleagues, or like they are not. There's not a system in the hospital that makes them jump in front in line, or the only thing where they are really like for real working is I think when they join the meetings. So they don't have a real role in the facility, if that was the question. Yeah. They just guide the patients in going into or referring or urgent referrals, and they come in to ask questions, and they come in to join the MDT and the ward rounds. And the only time when we observed them maybe how do I say that, function in the hospital was during the ward round, while going and seeing the patients individually together with the group. So then they were maybe part of the healthcare system. But I don't know what the legislation is about that. I just observed in the hospital that it happened, and it was working quite well. And the doctors were very happy about it. The social workers, physiotherapists, it was a nice teamwork going around.
Thanks, Lotte. Kosi, you had a question, and then we'll go to Vanessa's question in the chat after Kosi's question.
Thank you so much. In your presentation, you mentioned the WhatsApp group as an effective communication tool, and that the CHWs find quite helpful. And I think you mentioned something about referral pathway. I'm very interested to understand during your study if you observed if there was any feedback loop from the community health workers to the clinicians, and if WhatsApp was the main form of feedback, the WhatsApp communication tool, because in our experience, there's various forms of feedback references. So I'm just keen to understand if you've observed that during your study, how did the CHW provide feedback to the facility? Did they rely mainly on WhatsApp, or were there any other form of communication tools?
Yes, good question. So we didn't give a clear overview of all the types of interaction. We have it, but we had to keep it short for our 30 minutes today. We see in the referral system that they have digital referral forms, and they use it mostly via Google Form. And that's also a way that they are giving feedback. So the official way of referring is via the Google Form or via paper referrals, and the feedback goes also via email, the Google Forms, back to the facility. via the substructures. So that's the official way of referring. But we noticed that when there was some need for quick action, that it goes via WhatsApp. And that the quicker feedback also goes via WhatsApp, especially when people have these personal connections or doing home visits, for example. When there is quick questions for the registers, we do see that there's sometimes quick feedback via WhatsApp about some patients that the register saw on home visits, for example. But the most official way is via the Google Forms. And then I'm thinking there's other ways. Yeah. So you have the ward rounds as well. So in one region, they do joint ward rounds. And there sometimes people get referred directly, like, okay, this one will be when discharged, this one will be for follow-up for CBS, this patient. And then that feedback comes exactly right back because they see each other weekly. That feedback comes in every week on those ward rounds when there is something important. So in-person feedback is also the case. The only thing that we noticed is missing is you can do it on the MDT, but some registers mentioned that there's not about the way it works, regular feedback moments. For example, about doing those home visits, they did the home visits, but there was not a feedback moment about those home visits, for example. And that was an upcoming question to install moments for official feedback about those home visits.
Thank you. We're going to Vanessa's question in the chat, and she asks, were there any mention regarding data collection systems? Easy, difficult, time consuming, etc. So I would assume, Vanessa, do you want to unmute and ask your question and give a little bit more detail?
Sure. Good afternoon, everyone.
Hello.
Yes, I was just interested. I don't know. So we use a bit of the CBS data, but I'm always on the receiving end. So I was just curious from their perspective, how to find the IT systems or data systems as part of the capturing and data collection process.
I'm not sure that came up, but I mean, can one of you answer that?
Is the question, did I get it correctly that you're asking about how they collect and keep their data about their referrals?
Yes, yeah, just how they experience that system and if it's working for them and
Yes.
capturing what they want to convey.
We got very positive feedback about the statistics that are being kept about referrals. So since it's going via Google Form and those official referrals, they see how many referrals are in this specific area and that area, and about what topics, like is it maternal health, is it another topic. So they keep on that data properly, and then they get feedback, I think, was it every month, from how many referrals there were and on what topics. So they found it very useful. We got a feedback from one of the CBS nurses that she was really happy about those data because it makes them see where are the gaps and where do we need to improve or referrals in. Also, the family physicians get this feedback and they see, okay, this is in this region upcoming, or we see that the referrals are decreasing in this for this specific thing. Is there a reason for this? And they do make use of it. They're actually quite happy about getting that statistical feedback. We did not include that in our presentation because we had a lot of data. So we had to choose some of our main focuses, but we do have a couple of participants talking about their happiness about the statistical feedback, if that's an answer on the question.
Yeah, and I think we do share their enthusiasm about the statistics because I think there's great potential, and they've mentioned it as well, to address certain problems, to get that feedback. yeah, I feel like they're very enthusiastic about it, and then there's that there's still great room for improvement and to do even more with it.
Thank you.
Thank you.
Sorry, can I just follow up with that question
Yes.
from Vanessa?
Yes.
Sorry. With
Go for
regards to the Google Forms, were they accessing these Google Forms from a mobile phone, or were they using a desktop? Sorry, I don't yeah. And who was having access? Was it the OTL nurses, or was it the community health workers themselves? Sorry, lots of questions.
I think mainly the referrals, I saw it happening via the desktops. So they had a desktop in their hub, in their CBS hub. I didn't see them using their phones. So I think it's mainly via the desktop. And the second question was about...
So the second question was it the community health worker that was capturing the information on the Google Forms, or was it the OTLs?
Yes, so those goes all via the OTLs, and then they divide the home visits through the CHWs. So that communication goes via them, that feedback also goes via them.
Okay, so the CHW would do a collection on like a paper-based system, and then they'll report that to the OTL, who will then
Yes.
capture on the Google Form. Okay, thank you.
That's how we understood it, yes.
Thank you. So, Colin, okay, I see Sikulile.
Yes, so I'm just curious about the level of training for the CHWs, and were there elements that maybe might have been missed that were later included, later on, or that maybe you necessarily feel needs to be included in future?
You mean specifically to the CHW training?
Yes.
I don't recall there was information about the feedback about the training. What we mostly heard was feedback from facility staff that weren't completely aware of their level of training, and where they just didn't really know where the gaps specifically were. But some mentioned that if they knew better their level of training, that this could be the most important factor to tackle, that they could, if they had a better awareness of their level of training, so they could adjust the way of cooperation. More that than mentioning that certain aspects should be included in their training.
What we noticed on the member checking, to add to that, is that they are very open to learn more and retrieve more training. We got one element for us that stood out in, I think, 2 interviews was the mental health referrals, because they want to focus more on mental health referrals in both in the areas, and include more of the psychiatry patients as well in the MDTs. But the knowledge about mental health was very limited, and it was still a taboo. So that's one topic that's been raised for more training for the CHWs. But there were more topics, not specific topics, but there was mentioned that, okay, we can use some refresh moments about topics after we've worked in the field, and that would be very beneficial. But I cannot tell you which specific topics. A
suggestion we've heard, a suggestion we've also heard that, and is perceived very well, is that the registers, when they go into the community, they also organize talks, educational talks, for the CBS workers, including topics that they bring on. And as Lotte said, mental health was a big one specifically. But it depends on what area, what topics are very prominent, and which topics they could use extra information on. And it was perceived as a really good thing that the registers could give more information and organize these educational talks.
Yeah, the issue of adequate training for CHWs is an ongoing discussion. I want to round up our conversation by referring to Alicia's very pertinent question in our chat. I can read it out, Alicia, but if you want, do you want to ask your own question, and then that can be the final point of discussion for this afternoon?
Sure. I'm very aware of the issue of equitable research and people coming from other countries as outsiders into the South African research space. Just in terms of, the Lancet has brought out a position statement on parachute research, where people come from high-income countries, come and do research in South Africa and take that research and publish it, etc. So, like, how is that taken into account in terms of ethical and equitable research partnerships between the high-income and low-income, middle-income countries, in terms of, like, your positionality in this research as people coming from outside and discussing with people within the South African space, and how were you seen in the research, and what does it actually mean that lest you be accused of doing parachute research by just taking information from South Africa and using it for your own academic purposes? Yeah,
that's a really good question. Thank you. I think we try to be aware of this while conducting this research, because we discussed with Professor Ras to focus on, okay, what will be the research topic, what is necessary for our region here, for the Cape Town health districts, and what are the questions locally, and how can we conduct that research and be of added value for the local system. So we did not really focus in our research about how can we extrapolate it to Belgium. We will take it in account for when we are doing our pilot project, and maybe in the future. But for now, we really focused on the added value of our research project for the local teams. So I think that's what we try to do. And that was in discussion together with Dr. Ras to make sure that it was an important research for this region. We personally had an interest in community-oriented primary care, so we were very curious what is the added value of them in other countries. But we are very aware of the fact that it's not going to be the same when having CHWs here in Belgium, as our function as a family physician is also different than the family medicine, the family physician's functions in South Africa. So we haven't really discussed it in our data analysis yet, but we will definitely take it in account, the ethical considerations about this research project. I think it's a really good question.
And also, sorry if I can add something. Also, I've talked about the member checking that we've organized in September. One purpose of it is methodological, that we to make sure our data has been interpreted the correct way, but also to bring back the findings to the participants and discuss these, because they're also very interested to know what came up, and to have this information to do something about it and to help improve this interaction. So we made sure that these could be planned with them as well, so that the data comes back to the participants.
Yeah, no, thanks for that. When I see papers, for example, that have these certain sort of methodologies, etc., and I'm asked to review a paper like that, I think it's best, if you're going to write a paper about this, be upfront about those things. As a reviewer from Africa reading these sorts of things, one is very aware. And so, be very upfront about that in your papers published from this, and just how those local partnerships were part of the actual research as well. So thank you very much.
Excellent.
Well, thank you for the question.
Thank you, Alicia, for that question, and thank you, Cédric and Lotte, for presenting so succinctly and taking your time and providing thoughtful answers to the questions raised to you. Colleagues, thank you very much. It's been a fantastic afternoon with you this afternoon. A really deep discussion, and we do hope that we're going to have further engagements with University of Kent going forward in a decolonial manner, Alicia, as we strive to be. Thank you very much. Bye-bye.
Thank you all for your presence and your input. Thank you.
Thanks very much.
Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Okay. Bye-bye. Well done. Really, very
Bye,
good
thank
presentation.
you.
Yeah, I
Thank you.
enjoyed it. Yeah, went very well. I think Dash touched on all the important parts of it. Obviously, when you're writing the article for publication, you can touch on a lot of the other aspects. And maybe it's quite important, the last question. So, but normally there'd be a reflexivity statement as part of your methodology. And just say how, exactly as you answered, Lotte and Cédric, how you structured from generation of the research question all the way through to data analysis and data verification, how that process engaged with the local community rather than, saying we're going to take this internationally and answer international questions. Well done.
Thank you.
Thank you.
Okay, bye-bye. We're going
Bye.
the session is being recorded and then will be uploaded to YouTube. So you can share with your colleagues at University
Okay, that's
of Kent.
good. Super,
All
thank
right.
you.
Bye-bye.
Bye.
Bye.